Welcome to everyone. My name is Antoni Torres. I am a professor of pulmonology at the University of Barcelona, and I am an expert on respiratory infections, and my field of research is respiratory infections. This is an overview of the pneumococcal disease caused by Streptococcus pneumoniae, which is a gram-positive bacterium with more than 90 distinct immunological serotypes. On one hand, is the main cause of community-acquired pneumonia. The most severe disease, or the most severe pneumococcal disease, is the invasive pneumococcal disease, IPD. And we call IPD when there is bacteremia, both in children and in adults. This bacteremia can be from pneumonia or from other sources, or sometimes without source. We call IPD when there is meningitis, and we call IPD when there is pleural infection, including empyema. The epidemiology in European Union, the cases per 100,000 population, cases of IPD, 6.4 cases overall, but in infants less than 1 year, 14.4 cases, and in adult aged more than 65 years or 65, 18.7 cases per 100,000 population. The main drivers for the requirement of vaccination are age and risk factors. In children less than 5 years, all of these children have to be vaccinated. In children 6 to 18 years, it depends on the presence of risk condition or immunocompromise, or they are immunocompromised, such as the CSF leak, chronic liver disease, cochlear implant, diabetes, asplenia, splenic dysfunction, chronic hepatic disease, chronic kidney disease, chronic lung disease, and the maintenance dialysis or nephrotic syndrome. In adults between 19 to 65 years, again, it will depend on the risk condition or if they are immunocompromised. Immunodeficiencies, immunosuppressive or radiation therapy, HIV, hemoglobinopathies, alcoholism, smoking, drug use, homeless, chronic hepatic disease, chronic lung disease, chronic renal failure, and nephrotic syndrome. And in adults, 60 years, with 60 years more, all of them, in all of them, there is indication for vaccination against pneumococcus. Well, there are two types of vaccines to protect against Streptococcus pneumoniae disease. The first type is the pneumococcal polysaccharide vaccine, the PPSV23, that contains 23 pneumococcal polysaccharides aimed to protect against most common IPD causing serotypes in the 90s. It is recommended in adults 60 years or more, and anyone with 2 years or more with a risk condition, as mentioned before. The other type are the pneumococcal conjugated vaccines, the PCV7 in 13, and in that vaccines there is a carrier added, protein carrier added to the vaccine that confers a better immunogenicity. The PCV17 was followed by an increase in 90 infections, and the PCV13 use an increase in 35 infections. PCV13 may be used in certain pediatric groups and is no longer routinely recommended in adults because we have now the new generation of vaccines. In the table, you can see the serotypes covered by these vaccines, the PCV7, the PCV13, and the polysaccharide vaccines 23rd valent. As you can see, the PPV23 cover more serotypes, but the effectiveness is lower compared to the PCV13 and the PCV7. There are several limitations of first and second generation pneumococcal vaccines. On one hand, the PD serotype replacement has led to inadequate coverage by available vaccines. And recent community-acquired pneumonia and invasive pneumococcal disease studies show prevalent serotypes not covered by vaccines causing PD burden in adults. The PCV7 and 10 cover fewer serotypes versus the PCV13. The PCV13 covers fewer serotypes versus the 23rd valent, as I said, is more effective and produces a better immunogenicity effect. And the PPSV has poor immunogenicity and effectiveness in preventing pneumococcal pneumonia. The 23rd valent polysaccharide poorly immunogenic in children less than 2 years and does not elicit immune memory response or herd immunity. And older adults and people with chronic or immunocompromising conditions may also respond poorly. And finally, multiple doses of the polysaccharide 23rd valent vaccine required in children and immunocompromised patients owing to waning protection with the lack of T-cell dependent immunity. Well, there are several barriers very well identified. The first one probably is the lack of awareness by clinicians, not specialized clinicians, and patients about the existence of pneumococcal vaccines and about the importance of the burden of the disease, of the pneumococcal disease. After COVID, probably this changed a little bit because we are more worried about the respiratory infections that can be prevented. This is the first one. The second one is the opportunity to vaccinate these people. In several hospitals, there is not the logistics to vaccinate the patients after hospitalization, for example, or after going to the emergency department for a respiratory infection. This is important. And the third is the vaccination fatigue that the patients and probably the physicians and clinicians as well about vaccination. So it is very important to set up a strategy for co-administration, and then when the patients go for flu vaccination or COVID vaccination, then give the patient a precise schedule for pneumococcal or administer pneumococcal with flu. But overall, the rate of vaccination is low, and I know data from France, for example, that the rates of vaccination after COVID increased in immunocompromised, but decreased importantly for the overall population. Welcome to everyone. My name is Antoni Torres. I am a professor of pulmonology at the University of Barcelona. And I am an expert on respiratory infections, and my field of research is respiratory infections. As I said before, there is an evolving burden of pneumococcal disease and invasive pneumococcal disease in adults. We have here several examples for a European Systematic Review 2010-2022, in which the serotypes 8, 12F, and 22F represent a significant proportion of pneumococcal disease and invasive pneumococcal disease. And the serotypes 10A, 11A, 15B, and 22F represented serious fatal cases. Other serotypes not covered or not completely covered, but the current vaccines affected adults, immunocompromised individuals, and those with comorbidities. There are other studies, for example, in the UK cohort, again, showing that the serotypes 3 and 8 were prevalent in community-acquired pneumonia cases. The Italian cohort study showing that serotypes 3, 8, 11, 8, and 22F were the most common in adults with community-acquired pneumonia. The CAPA Spanish studies that showed that serotypes 3 and 8 were very prevalent in community-acquired pneumonia cases, and the US Pneumo study in which serotypes 3, 22F, 35B, 9N, 19F, 23A, and 11A were the most common. The different serotypes covered by the PCV13, the PCV15, the PCV20, and the new vaccine, the PCV21. And you can see, according to the studies mentioned, that the new vaccines cover some of these serotypes that are not covered by the second generation, let's say second generation vaccines, and that really are included in the next generation vaccines, the new generation vaccines. So the evidence is clear that there is a shift in the epidemiology of serotypes and the appearance of serotypes that were not covered by the previous PCV13 and PCV15 and PCV7 vaccines. It is important to know that serotypes are not measured and confirmed in the clinical practice, but in the CAPA studies, they performed the measure of serotypes or determination or confirmation of serotypes in the urine for the IPD patients and for the non-IPD patients with an immunochromatographic assay. And this, in our own experience, we observed several cases of the serotypes not covered in the PCV13, but covered potentially by the PCV20. First, let's talk about the key efficacy data in infants and children for PCV15, for PCV20, in both categories. There are several trials performed with important inclusion of patients. The majority of them were randomized. The dosages in healthy infants were 4 dose regimes, and the children, the age-appropriate catch-up schedule recommended by ACIP. And the key outcomes in all of them were the non-inferiority for immunogenicity. And this was confirmed in the 4th studies for healthy infants and for children for the majority of the serotypes included in the vaccines. That means that these vaccines are effective in terms of immunogenicity to be administered in children. And then let's see the key efficacy data in adults, the phase 3 studies in patients 18 years or older, 50 years and older, and 65 years and older. Regarding the PCV20, in this very huge population, the OPA GMT titles were non-inferior, and this criteria was met for the PCV13 matched serotypes in adults with 60 years or more 1 month after the administration of the vaccines, or 6 of 7 extra serotypes in PCV20 versus PPV23, and in adults 50, 59 and 18, 49 years versus 60 years or more. In the population of 50 years or more, 2 studies, the PCV21 Stride 6 and the PCV21 Stride 3, and the PCV15 Pneumo Edge trial, all of them showed that the OPA GMT titles measured after the vaccination, 1 month or more, there was non-inferiority criteria met comparing the serotypes or the immunogenicity caused by the administration of PCV13. And the same happened with the population of 60 years and more. That means, again, that these new vaccines that cover new serotypes not included in the previous vaccines are effective in terms of immunogenicity to be used, in that case, in adults and the elderly population. Well, the new vaccines are really very safe and compared to the previous vaccines, and we can say that they are dissimilar. PCV15, PCV20, or PCV21, the adverse effects were mostly mild to moderate with short duration, and the same happened in the PCV20. The side effects were mostly mild to moderate, and for the PCV21, again, the adverse effects were acute and mostly mild to moderate, and this was confirmed for the PCV13 in children, in young people, and in adults, and PCV20 in children, adults, young adults, and adults, and for the PCV21 in adults. There were not observed long-term side effects, and overall we can say that these vaccines are safe with similar side effects compared to the PCV13 observed in the previous trials. So the factors to consider when selecting a vaccine now, after all the data that we have in our hands, are the following. Of course, age continues to be an important risk factors to consider the vaccination against pneumococcal disease. Immunocompromised patients is another group of population or patients that, of course, have to receive these new pneumococcal vaccines. The vaccination status is important because this is going to condition the time to administer the new vaccines and the type of the new vaccine. Of course, again, the risk conditions have to drive the vaccination of the patients, and the patients will be divided in high-risk condition or at-risk condition. For example, a risk condition means a chronic comorbidity. The fourth one or the fifth one is the co-administration, because this is a very important point, since we want to administrate, for example, the influenza vaccine, perhaps the same day that you want to vaccinate a bit against pneumococcal disease. And finally, as I said before, the local serotype emergence and surveillance is crucial in each country to decide if we need to include the new vaccines in the calendar of vaccination. Welcome to everyone. My name is Antoni Torres. I am a professor of pulmonology at the University of Barcelona, and I am an expert on respiratory infections, and my field of research is respiratory infections. These are the updated ACIP guidance for children 2023. And the recommendations are divided in the following groups. To 23 months old, all PCV-naive children to receive PCV15 or 20, 24 to 71 months old to receive PCV15 or PCV20 if PCV vaccination incomplete. And this group is going to be divided in 3 groups, 24 to 59 months healthy. Recommendation 1 dose, 8 weeks after the last PCV dose. 24 to 71 months risk conditions, less than 3 PCV doses, 2 doses, 8 weeks apart, and 24 to 71 months risk condition, 3 PCV doses before 12 months, 1 dose 8 weeks after last PCV dose. The third group is 2 to 18 years old with risk condition, completed PCV series before 6 years of age. If complete with 1 or more PCV20 dose, no action is required. If complete with PCV13 or PCV15, 1 dose of PCV20 or 1 dose of more dose of the polysaccharide 23rd, and if PPV 23rd used and they are immunocompromised, 1 dose of PCV20 or PPV 23rd more than 5 years after the first vaccine of the PPV 23rd was administered. And the final group, those young patients between 6 and 18 years old risk condition did not receive any PCV. Recommendation is a single dose of PCV15 plus polysaccharide 23rd 8 weeks after if never given, or the PCV20 8 weeks or more than weeks after the last dosage. Again, these are the ACIP guidance, but this time they were updated in 2024. And they apply to the population 19 to 64 years or 64 years or more, 65 or more. Let's see the recommendations for 19 to 64 years in immunocompromised CF leak or cochlear implant. And there are several groups here. No prior PCV or PCV7. Administer a single dose of PCV21, PCV20, or PCV15 plus polysaccharide 23rd, 8 or more weeks later. Prior 23rd vaccination, a single dose of PCV21, PCV20, or PCV15 1 year or later. Prior PCV13 only, single dose of PCV21 or PCV20 1 year later, or a PPV23rd 80 weeks later, plus a PCV21, PCV20, or PPV23rd 5 years later or more. The two last groups are prior PCV13 or 1 dose of polysaccharide 23rd. Then the recommendation is a single dose of PCV21 or PCV20 5 years or more after the last PCV dose, or 1 dose of the polysaccharide 23rd 8 weeks after the PCV13 dose, and 5 years or more after the first 23rd valent vaccine, then the 23rd. And review when patient turns 65 years. And the last group, review when patient turns 65 years or a single dose of the PCV21 or PCV20 5 years or longer after last PCV dose. And for chronic medical conditions and for the first two groups, the recommendations are the following: a single dose of PCV1, PCV20, or PCV15 plus the 23rd valent 1 year or later, a single dose of PCV21, PCV20, or PCV15 1 year later, a single dose of PCV20, PCV20, or 2120, or a polysaccharide 23rd 1 year or later. And for the fourth group, that is the prior PCV13 plus 1 dose of polysaccharide vaccine 23rd, the recommendation is a review when patient turns 60 years of age. And this is the updated ACIP guidance for adults. The date was published in 2024, so this year. And this is the population 65 years or more. And there are here 5 groups. No prior PCV or PCV7. administer a single dose of the 21 conjugated, the 20, the 15 plus the 23rd, 1 year or later, or 8 weeks or more or later, if immunocompromised, the population is immunocompromised, or with cochlear implant or CSF leak. For the second group, prior 23rd valent administration, recommendation is simple: single dose of PCV1, PCV20, or PCV15, 1 year or later. For the group of prior PCV13 only, administered before, simple: single dose of PCV20, PCV20, 1, or PPV23 polysaccharide 1 year later, or 8 weeks later if immunocompromised or with cochlear implant or CSF leak. For the fourth group, that is the prior PCV13 at any range or PPV23 at age of 65 years or more, or less, a single dose of the 21 conjugated or the 20 conjugated 5 years or later after the last PCV dose, or administer the 23rd valent 1 year later, or 8 weeks if immunocompromised with cochlear implant or CSF leak, and 5 years after the last PPV 23rd dose. The final group is the group of prior PCV13 at any age, plus the conjugated at age 65 years, the polysaccharide at age 65 years or more. This will be a shared clinical decision on whether to vaccinate further, the clinician and the patient, shared by both. If a single dose of PCV20 or PCV21 used, give 5 years, give a dose after more than 5 years later, or 5 years after the last PCV dosage. The ability or the possibility to co-administer one vaccine with other vaccines is very important, because you reduce the burden of administrative issues and the logistics. And this is possible in pneumococcal vaccines. In children, the PCV15, the PCV20, or the polysaccharide 23rd can be administered with most of the routine childhood vaccines. The PCV15 and the PCV20 can be administered with flu vaccine, but there is increased risk for febrile seizure with inactivated vaccine. No data is available on the polysaccharide 23rd and the co-administration. For adult, the pneumococcal vaccines, the conjugated, can be administered or co-administered with other vaccines, but you have to consider the contraindications, including flu. You have to inject at different sites, and flu is important to know that elevates the risk for pneumococcal disease. Important to provide both vaccines where possible. Some special considerations. The co-administration cannot be performed for PCV13 and the meningococcal vaccine in anatomical functional asplenia and or HIV owing to reduced immunogenicity. Then administer the PCV13 first and the meningococcal vaccine 4 weeks later. And finally, when both PCV13 and PPV23 are recommended, administer these separately. Well, taking into account that in several countries and after the inclusion or the implementation of strategies in children and adults with the conjugated vaccines, a shift in the serotypes not covered by these vaccines have been observed in several countries. And there are modeling studies that suggest that in United Kingdom, and United States that PCV20 may markedly impact an invasive pneumococcal disease owing to higher invasive of additional serotype covers. And the same type of findings in these modeling studies have been shown in the US experience of publications. So this is important because these new vaccines eventually and potentially are going to change the frame and the burden of the disease regarding these serotypes not covered in previous vaccines. The new conjugated vaccines are not introduced in a lot of countries, mostly the Occidental world. In the Occidental world, these vaccines are available and implemented in the recommendations. Since they are implemented in the ACIP recommendations, this is going to have a great impact in those countries that do not have the vaccines. On the other hand, the lack of the epidemiology of the serotypes in many countries is another issue that does not help. And in Asia Pacific, in South America, a lot of countries do not have, in Africa, do not have these epidemiological studies to try to search for the different shifts in serotypes, and this is important. So these studies should be performed, and then if there is a shift in the serotypes, this will have a major impact in the recommendation for the third generation vaccines.